What's up, guys? Today we're going to cover congestive heart failure. So I am updating this video slash podcast as of December 2025. This was one of the first videos actually I ever made for PTA Elevation. I think it was like my third video ever. So we gave it a little facelift. If you watched the previous one, it's still good. Just I feel like this is our new and improved congestive heart failure video. So, woo, new things. So let's talk about it. Again, anatomy is super important for understanding our whole thing with congestive heart failure because we need to understand where is blood flowing through the heart, where are the chambers of the heart, where are the valves located in the heart. If we understand all of this, it makes perfect sense why we see congestive heart failure causing problems in the extremities or problems in the lungs, depending on what side is affected. So let's just kind of recap everything. Again, if you're listening to this in audio format, you might not be able to really see, obviously you can't see what I'm talking about, but if you can pull up a picture of a heart at some point, that would be great, or we'll look this up on YouTube. Anyways, so the biggest thing is we start with blood coming into the heart from the superior vena cava, bringing blood from the like brain and everywhere and the extremities or the upper extremities, and then we have the inferior vena cava basically bringing blood in from the rest of the heart. Now, both of these are going to empty into the right atrium, so right side of the heart is where we start, and then we're going to go through the tricuspid valve into our right ventricle. From there, blood will go from the right ventricle through the pulmonary semilunar valve into the pulmonary artery. Now, the pulmonary artery has deoxygenated blood because it's coming from the rest of the body. So it hasn't gone to the lungs yet. We're taking the blood from the heart to the lungs. It's still going away from the heart, so it's an artery. And so the pulmonary artery will then go to the left or right lung, such as life. It's going to go to the lungs, get oxygen. Makes sense. It's what the lungs do. And then it's going to go through the pulmonary veins. Remember, veins bring blood to the heart, okay? It might be oxygenated, it might not be. But here's the thing. When we have the pulmonary veins, it's going to be oxygenated blood. Generally, all the other veins are carrying deoxygenated blood. That oxygenated blood is going to go into the left atrium, which then is going to go through the mitral valve, aka bicuspid valve. And then it's going to go into the left ventricle, then that's going to go through the pulmonary, I'm sorry, not pulmonary, the aortic semilunar valve. And then it's going to go out through the rest of the body, through the aorta, up until all the major arteries, and give blood to the body. So, again, that last valve there would be the aortic valve, which is where the left ventricle pumps blood into the aorta. Makes sense. So, now that we know what's going on, we can kind of see this also has things color coded based off of oxygenated versus deoxygenated. Let's look at what's going on with our pathway of blood through the heart. So, I wrote it all out for you guys. So you guys will be able to see this visually with the color coding too, so you can see which side is going to be our oxygenated blood versus our deoxygenated blood. So again, this is a recap of what I just said. I'll just quickly go through it. Pathway of blood through the heart. We're going to have the vena cava going into the right atrium, going through the tricuspid valve, going to the right ventricle, to the pulmonary semilunar valve, to the pulmonary arteries, to the lungs, where then the blood gets oxygenated, then through the pulmonary veins, to the left atrium, to the mitral, aka bicuspid valve, to the left ventricle, to the aortic semilunar valve, to the aorta, to the body, where then it goes, delivers oxygen to the parts of the body, and as it comes back up, it's going to be deoxygenated by the time it gets back to the heart. Makes sense. So, etiology, how is this happening? The heart cannot meet the demands of the body and it begins to fail, okay? So, insufficient filling due to the heart working too hard, which means that the heart muscle would begin to enlarge. Just like if we were going to use our biceps a lot, they would eventually get bigger. Same thing with the heart. If you use your heart too much and it's contracting too forcefully, it will hypertrophy and the muscles will get bigger. As the muscles get bigger, it's going to shrink the space in the ventricle, so there's not enough space for blood to get through. Think about somebody with a giant bicep that can't bend their arm enough, like flex their elbow enough. They're unable to do that because there's too much muscle in the way. Same thing with the heart. There's not enough room for blood to get in because there's too much muscle in the way. Now, again, this also can happen due to dilation of the heart muscle, causing insufficient contraction of the heart muscle. So thinking of if you have like a hair tie and you stretch, or a rubber band, and you stretch it and stretch it and stretch it and stretch it, eventually you get to the point where if you wanted to try to stretch it and slingshot it at somebody, it could be so stretchy that just kind of like flops down. So that's kind of what's happening with the heart when it's dilated too much. The blood, like the walls of the heart become so stretched out they can't contract and squeeze. Kind of like how if you stretch out a rubber band or a hair tie too much, you can't slingshot it at somebody. Same thing is happening in our bodies. So, because of this, we're going to have a significant issue with contracting the heart to push blood through the body. Pushing blood out of the heart and into the body is an example of our cardiac output. We'll talk about that on the next slide. But again, these two phenomenon of the heart muscle being too big or the heart muscle being dilated, these are called cardiomyopathy. Very common cause of our congestive heart failure. However, there's a bunch of different causes. I just wanted you to be aware of these two because I feel like they show up sometimes and it's easier to visualize how cardiac output is turning to crap for less of a better explanation because the heart doesn't have enough room for the blood or the heart can't actually pump the blood out. Makes more sense visually for me. It helps me understand. Just wanted to throw that out there. Now, again, there are many causes of congestive heart failure. The biggest one is hypertension, okay? So hypertension is the number one cause of like pretty much every heart issue out there. I'm sure as you've been studying these heart pathologies, you've noticed wow, everybody's got hypertension and it's causing lots of problems. Yes, that is a big one. Just notice there's subtle differences and different etiologies and reasons why different heart pathologies show up, but understand if we can get their blood pressure down, we're going to solve a lot of issues. So, coronary artery disease, another one. So, CAD, that's due to the increase in plaque buildup inside of the arteries, causing arterial sclerosis or atherosclerosis within the arteries of the heart. Again, if we're having a buildup of this plaque, we can't get blood through. That's an issue. Myocardial infarction, that's going to be a heart attack. So, again, that can cause problems. Valve disorders. So as we talked about earlier, a big one is the mitral valve. So if we look here at our mitral valve, oop, nope. Here's our picture, a mitral valve being our between our left atrium and our left ventricle. If that causes some problems and we can't get blood into our left ventricle, or it's faulty, or it's backwashing or something, we're gonna have an issue with the amount of blood that ends up in the left ventricle and the ability for the heart to pump. So if that mitral valve isn't working, we're gonna have issues with blood being able to get into the ventricle and or blood being able to stay in that ventricle when it's supposed to. So again, we have renal failure. Again, if our kidneys go, that's bad. It's going to mess up a lot of things. They regulate getting all of the fluids out of our cardiovascular system. So if they're not working, we got issues and it's going to cause our heart to overflow with blood. That's why people end up on diuretics who have congestive heart failure. Pulmonary embolisms, again, that can cause heart failure because we're messing with the lungs and the blood flow into the lungs. Myocarditis is an inflammation of the lung. Sorry, not the lungs. It's an inflammation of the heart muscle. So that definitely can cause issues. And again, this can be right-sided or left-sided. So we're going to talk about that in just a moment. So let me just explain this little bit of cardiomyopathy first. I just want to give you a visual. So again, normal heart, we can see the muscles and everything. If you're listening to this on audio, sorry, you can't see this. We're gonna have our heart muscle, and again, if we have the hypertrophic cardiomyopathy, where there's increase in the heart muscle size, you can see this ventricle space got super small. So again, if we don't have a lot of blood entering the left ventricle, it can't go to the body. Problem. Same thing with this dilated cardiomyopathy. We have this really dilated muscle, so we can get blood in, but it's not strong enough to slingshot all that blood out, just like how it wouldn't be strong enough to, it's all stretched out. So it can't contract easily. So that's going to be our issue here with our dilated cardiomyopathy. Now, again, big thing to think about with our heart failure is cardiac output. So cardiac output is equal to stroke volume times heart rate. If stroke volume decreases, heart rate will increase. This is what happens to people on bed rest. So again, if stroke volume decreases, heart rate's going to increase to compensate to maintain that same level of cardiac output. If stroke volume increases, then our heart rate's going to decrease to compensate for that. So thinking of a resting heart rate in somebody who's a marathoner, somebody who does extreme endurance workouts and stuff like that, they are very physically fit with their heart muscle. So their heart muscle doesn't need to contract as often because the stroke volume has increased to a significant amount that we don't need to have our heart beating all the time. We can kind of conserve that energy because the heart muscle is strong. So big thing to think about with cardiac output, it's an inverse relationship between stroke volume and heart rate. Um, If we have our stroke volume decrease, the heart rate will increase. That's what happens on bed rest. And again, if stroke volume increases, our heart rate will decrease. And that's like what happens with endurance athletes. So let's talk about right-sided versus left-sided heart failure, though. This is a very important point to understand. So right-sided heart failure can happen due to a number of reasons. One of the more like common things you'll see on the boards when it comes to a specific type of right-sided heart failure is this phenomena called cor pulmonale, and it's going to be happening due to increase in blood pressure in the pulmonary artery. This is usually due to the fact that the patient has like COPD or some other lung pathology that's causing the right-sided heart failure. Again, if the lungs are messed up, the last place where blood came from is the right side of the heart. So we're going to see that end up being the essentially punching bag of this disorder. So essentially, what's happening is we're going to have an increase in blood pooling up in the right side of the heart because it's not efficiently getting to the lungs. That's how I like to think about it with these heart failure things. So, with that being said, let's talk about all over right-sided heart failure. So, core pulmonale is its own little thing. You can read about it. True, just regular run-of-the-mill right-sided heart failure is going to be fluid retention in the extremities. So, good thing to think about with heart failures. I think about it like a car crash. Okay. So, if we have a car crash on the highway, all of the cars, like let's say crashes in between, I'm just thinking of where let's say it's between Route 1 and Interstate 2, okay? So Route 1, Interstate 2, there's a car crash there, okay? So it's on the interstate and we'll see all this backup happening down the highway, right? It's gonna back all the way up to the most recent exit because people are gonna try to be getting off there. We've all seen this happen on the highway. We know. So, anyways, thinking about a car crash as the part of the heart that's messed up. So, with the right side of the heart, we see that the car crash has happened on the right side of the heart. Blood is going to back up to where it just came from. So, where did blood just come from? Blood just came from the rest of the body. So, we're going to see blood begin to pool in the extremities bilaterally. It's this whole systemic thing. It's not saying I'm going to take all my anger out on the left leg. Nope, both legs are going to be involved. You're going to see this pitting edema, which I'll show you a picture of it. But if you've ever played with slime or seen the slime videos, it's like poking into that and you see, ooh, it's like leaving a little indent. That is pitting edema. So you're going to see that both sides. Another thing you could see is a jugular vein distension. So the jugular vein, which is on the external jugular vein, which is on the outside of your neck, you might see it pop out and be filled more with fluids. And that's because the jugular vein primarily brings blood down from the head. And the legs, obviously, is where you're going to see the majority of blood pool from the rest of the body. So those are the two big areas you would see right-sided heart failure problems. So I'd say think think rest of the body. So like think body, like the rest of the body. That's what that statement means. When you have right-sided heart failure, I think rest of the body. Okay. So body or think the R in right for the R and rest of the body. That's a good way to think about it. With the left-sided heart failure, though, we want to think of our problem being the lungs. So the lungs are going to be the problem with our left-sided heart failure. We're going to see all of the symptoms show up there. Why? Because the left side of the heart, if we just had like heart failure happen over there, it's messing with the left side of the heart. Where did blood just come from? So we see our accident pile up back to the to the last exit, which was the lungs. So for left-sided heart failure, think lungs. So again, you're going to have pulmonary edema. So that's a fluid backup in the lungs, literally what I've been saying. You're going to see the low cardiac output, of course, because this is where blood exits from the left ventricle to the rest of the body. That's where our cardiac output measure is coming from because it's blood leaving the heart, okay? Finally leaving the heart. We're seeing that that's decreasing. You're going to see this with hypertension, of course. I tell you all the time that that's a main issue. And other sort of cardiac arrhythmias can also cause left-sided heart failure. There's a whole list, but as for the boards, really just understanding that hypertension is like the major cause, different dietary, like excessive salt intake. These are all going to be big ones for left-sided congestive heart failure. Now, here are the pictures that I was showing you. So the pitting edema, you press down into it, you poke, and it leaves this little indent. Again, think of slime. Y'all have seen the slime videos. You press down, it gets stuck there. There's fidget toys where you press in, it gets stuck there. This is the jugular vein distension. So you can see that this external jugular vein is popping out. Looks almost like it's like a log in there. So again, these are both going to be signs of our peripheral edema. So, with the lung one, you can't really, obviously, you can't see the lungs because they're inside of you, but you can't see the lungs because they're inside of you. That was silly. That was a silly statement. I'm going to leave this in here though. With the lungs, the way that you're going to understand that there's a problem there is to auscultate it with a stethoscope. So again, hearing the lungs, hearing the crackles in the lungs, that's going to be your indication. Okay, yeah, this is going to be some pulmonary edema. This is a problem. So again, they'll have shortness of breath. That'll be another problem. Or they'll have this phenomena called orthopnea, which is difficulty breathing in supine, or nocturnal dyspnea, difficulty breathing at night, usually due to the fact you're laying down. It increases the fluid return to the heart and increases the amount of pressure on your heart due to the fluid, which causes difficulty with breathing. We already talked about the jugular vein distension and the swollen legs for the bilateral pitting edema with the right-sided heart failure. And again, with both of these, more so obviously with right-sided because it's going to be the whole body versus just a small portion being the lungs, but you're going to see rapid weight gain. I believe if it increases more than 10% of the patient's body weight within 24 to 48 hours, that's automatic ER. Like automatically you need to go to the emergency room because that's an exacerbation of their congestive heart failure. And this can kill patients. So keep an eye out for that. Again, boards is just saying, would say something like rapid weight gain. There's different parameters for different companies of what they use for their cutoffs for percentages. But generally, if we're seeing a rapid weight gain, we should be having our alarms off. And this is due to the fact that fluid's being retained and not excreted by the kidneys because it's staying in the system because our heart is congested. Makes sense. So, how are we treating this? We are not going to cure this. We're going to manage our patient's symptoms to keep them as functional as possible. Okay, so hopefully that makes sense. We are going to manage these symptoms to keep them as functional as possible. The only thing to truly fix it is a heart transplant, which a lot of these individuals end up not being candidates for due to other reasons. But again, in a perfect world, that would be our treatment for this patient. Again, in reality, we have to manage the patient's symptoms. They're going to be on pharmaceuticals, various different ones. Usually the first line of defense they're going to give them as a diuretic to try to get rid of all the extra fluid in the body. Just diurese them and hopefully everything turns out okay. Diet and exercise, we're referring them to a registered dietitian. I realized in the last time I made this video, I had to spell dietitian with a C. There's no C in dietitian. I'm sorry, dietitians. Sorry, my bad. Um, they're very on top of that. So just a fun fact. Different diet modifications that we can at least like suggest to the patient are like lower salt diets. They might be on fluid restrictions. So just checking their chart to make sure, okay, is the patient on fluid restrictions where they're only allowed a certain amount of ounces of water per day? We don't want to overload the heart. So just being aware of that. Again, PT interventions, we're working on conditioning and mobility. So getting them to do energy conservation techniques, pacing activities. We're educating their caregiver on all of these things as well. Working on functional things like transfers, getting them to walk farther distances, being able to do the things they want in the community, modifications, different assisted devices, whatever they specifically need. Again, just thinking of your general deconditioned patient that we have to teach energy conservation techniques and work on strength and conditioning. That's pretty much it. Nothing too complicated about that. Just obviously monitoring vitals as we go. So again, our keywords, peripheral pitting edema, so bilaterally, our jugular vein distension, that's another one that's going to show up for right-sided heart failure. Limiting their sodium intake because again, water follows salt. So if they have a lot of salt in their system, they're going to want to drink a lot of water, and then that's going to overflow their system with fluid. So lowering the sodium intake helps with that. If it's already overflowed, they're getting diuretics. Again, we're not prescribing, of course, but just being aware they might be on it. They might be going to the bathroom very frequently and being like, I gotta take my water pill. Let it happen. Let it happen in the toilet. Don't let them pee on the chair. Anyways, decreased cardiac output. We talked about that. Increased heart rate due to decreased stroke volume. That's what's happening here. Crackles, orthopnea, common symptoms of our left-sided heart failure. So those are our key words, and let's go into our sample question. Alrighty, a patient with congestive heart failure just completed 10 minutes on the recumbent stepper and is now walking to a chair and begins to feel dizziness and lightheadedness. What should the therapist do first? One, give the patient water. Two, wait 5 minutes and then resume exercise. Three, sit and check the patient's blood pressure. Or four, call the patient's physician. So I'll give you guys a moment to think about this one. All right, friends. So the answer is going to be sit and check the patient's blood pressure. So, important thing, when a patient is having symptoms that don't seem very good, our first step is to get them into a position where they're not going to hurt themselves, which could either be sitting or lying down. Again, if they have congestive heart failure, probably not lying down, probably sitting or a semi-Fowler's position will be ideal. But again, we're going to sit this patient down and check their blood pressure. That's what we should do first. So, looking at our other answers, what's going on here? One, giving the patient water. They're on fluid restrictions probably if they're having congestive heart failure. So again, the just not no. This is probably not a good idea. You might think like, any run-of-the-mill person, I'm feeling really dizzy. Oh, here's some water. And that could overflow a patient with congestive heart failure. So generally providing fluids to a patient with congestive heart failure is not ideal and usually contraindicated. Or at the very least, you need to be aware of how much you can actually give them. Just giving them water willy-nilly, not a good idea. Two, waiting 5 minutes and then resuming exercise. Three is just better. Like three is just a way better answer. Do you think that maybe we'll wait 5 minutes, they feel better, and we can resume? Possibly. That's an idea. There's too much like, well, maybe this will work out. Like you're creating too many scenarios in your head to make two be right. Three is like, regardless of what scenario we're in or what's going on with this patient, what they look like, what's happening, what their history is, sitting them down, taking their blood pressure and assessing vitals, that is just it's just such a golden answer that nothing else can compare to it. So two, while we might end up doing this after we check their vitals, three is the first thing we should do. Sit them down, check their blood pressure. Like there's no other answer that could compare to the beauty that is answer number three. And then four, calling the patient's physician. We're only doing this if it's like a very severe issue, like a medical emergency sort of thing, or if they need to be seen immediately for follow up. A patient just exercised, maybe they were sweating a little bit, they're on a fluid restriction, they stand up, they've been sitting down for 10 minutes, they're feeling a little dizzy and lightheaded. They probably just have a little bit of orthostatic hypotension going on. Again, this can happen with a lot of patients who are on medications like diuretics and stuff. I know it doesn't say the patient's on a diuretic, but since they have congestive heart failure, most likely they're on some sort of blood pressure management medication because that's the main reason why congestive heart failure happens is due to hypertension. Um, Even if you're not entirely sure, or there's nothing in the question that says, oh, they're on a medication. If the patient's feeling lightheaded or dizzy, regardless of what the patient has going on, it's good practice to just have them sit down and take their blood pressure with any patient, regardless of what's going on. That's a very safe and effective thing to be doing to give you some more information so you can decide what to do next. At this point in time, there is nothing warranting us calling their physician. Let's sit down, take blood pressure. That should be our first option. If you're like, let me call your physician, you walk over to the phone, you go call them, your patient passes out and falls on the floor and hits their head. That's not good. So that's why I'm like, four is like, we got to go through A, B, C, D, E, E before we get to number four to use that as our answer. All right, guys, hopefully you enjoyed this updated version of our CHF lecture. I'm sure it was a lot longer, but I'm sure you enjoyed the extra info. All right, bye guys. See you in the next one.